Hello, my name is Norbert Vey. I'm a hematologist at Institut Paoli-Calmettes in Marseille, France. The question is, what is a challenge for the patients with AML who have achieved a complete remission? So this is a very important question because with the recent improvement in the induction chemotherapy, approximately 70 to 80% of the patients do achieve complete remission. But unfortunately, the majority of these patients will relapse. The relapse is due to cells that persist after chemotherapy, and the mechanisms of resistance of these cells are multiple, which makes, of course, this issue more complicated. And there are different mechanisms, such as pharmacological mechanisms, including the drug intake or metabolism of the drugs into the cells. But there are also genetic mechanisms with some gene mutations like TP53 mutations, for example, that are associated with a resistance to drug-induced cell death. And more recently, other non-genetic mechanisms have been described, including the epigenetic deregulation and metabolic switch. So there are actually two different situations when we are dealing with the problematic of complete remission persistence, which are depending on the patient age. For the younger patient, the standard post-remission treatment is based on the administration of intensive chemotherapy. And it has been shown that the backbone of this chemotherapy regimen is the administration of intermediate or high doses of cytarabine. And this is followed by the administration of an allogeneic stem cell transplantation for the patients with intermediate or unfavorable cytogenetics. So how can we progress? The first source of progress is coming from a better risk assessment, which will make us more accurate in the indication of allogeneic stem cell transplantation. And in this regards, the recent development of the monitoring of minimal residual disease has been critical. The second possibility is to increase the intensity of the consolidation chemotherapy. And there have been a lot of attempts over the last 10 to 15 years with following this kind of strategy. But actually, most of these attempts have failed. And we are still now with the idea that intermediate doses of cytarabine are probably the optimum for the consolidation treatment. For instance, we recently reported at the last ASH meeting the results of a phase 2 randomized trial conducted by the Philo group, where vosoraxine, which is a new cytotoxic agent, was combined to intermediate doses of cytarabine, and the results of the study were negative. So I think that we have to look at the new drugs and that are non-cytotoxic drugs, like, for example, venetoclax, which has shown activity in a different setting, but which is currently tested by different groups, including the French AML intergroup in the setting of intensive consolidation chemotherapy. And we will know by 2 or 3 years if this kind of strategy is effective. The other interesting drugs are the targeted therapies, like for example, the tyrosine kinase inhibitors used for the treatment of FLT3 mutated AMLs, or the IDH1 and 2 inhibitors, for which several trials are currently looking at the effects of their combination to intensive chemo during the induction and consolidation therapy of the frontline treatment of younger patients. And finally, more preliminary drugs, such as, for example, the bispecific monoclonal antibodies directed against CD123 or CD33, could be also interesting as alternative to intensive chemo for the consolidation treatment, as it has been achieved, it has been shown, for example, for the treatment of acute lymphoblastic leukemias. So the second important aspect is what can we do to improve the results of the treatment of elderly patients, so that's patients older than 60 who have achieved a complete remission. As I said before, the situation is different from that of younger patients, because virtually all of these patients will relapse within 2 years. There are two major reasons for that. The first is that increased frequency of adverse cytogenetics in this patient population, or the increased frequency of patients who have secondary AMLs. And we know that in these two situations, there is more resistance to chemotherapy. But the other reason for the poor results of the treatment is also due to the patients-related factors, with a substantial proportion of patients who have become unfit for intensive chemo after the administration of the induction chemotherapy. And randomized studies that were conducted 15 years ago, where patients were randomized at the time of complete remission, showed that 20 to 30% of the patients could not be randomized just because they couldn't afford more intensive chemotherapy. So there is currently no standard approach for the post-remission treatment of elderly patients, and the superiority of intensive chemo has not been demonstrated. And for example, we recently, my group recently published a paper with real-life data coming from my institution, where we showed that the elderly patients who were treated with high doses of intermediate doses of cytarabine as consolidation treatment did not better than the patients who received less intensive chemotherapy approaches, although the intensive treated patients had more favorable features, including age, cytogenetics, etc. So the progress will come from the development of different treatment approaches. The optimization of chemotherapy is always possible, as shown, for example, with the experience with CP351, which showed better results as compared to classical intensive chemo in elderly patients with secondary AML, but the improvements are probably marginal. The other way to improve the results of these patients is to increase the proportion of patients who could be transplanted with new techniques like the haploidentical transplant or microtransplants, for example. We can also use the new non-intensive drugs that I mentioned before, such as venetoclax or the targeted therapies to change as alternative to classical consolidation treatment. And one more recent approaches that have been proved effective in these elderly patients is the development of maintenance strategies. Maintenance strategies are used for many years in the treatment of acute lymphoblastic leukemias or in acute promyelocytic leukemias, but were not shown very effective in AMLs. But this has recently changed with the results of the Quasar study, which is a phase 3 placebo-controlled trial where the patients were randomized to receive oral azacitidine so that the CC486 drug or placebo after achievement of complete remission. And the study showed the results that were presented by Andrew Vey showed that this the administration of this maintenance with this oral azacitidine was associated with clinically meaningful and statistically significant survival improvement. So I think that this is an important result because this gives a proof of the concept that maintenance could be useful in elderly patients with AML. And this opened the way for other maintenance approaches for which we can take the advantage of the recent development of new drugs, the targeted therapies, venetoclax again, but also new monoclonal antibodies targeting either TIM3 or CD47, for example, that have shown early hints of clinical activity in AML. For the future, the development of these new maintenance approaches in which we could probably combine the different agents gives us a lot of hope.